Let's jump right into this explainer because what we've got for you today is basically a rapid-fire survival guide. We are meticulously dismantling the absolute most dangerous cognitive traps in medical board exams, specifically focusing on burn management. Look, the examiners, they know exactly where you're going to stumble. So today, we're going to navigate this minefield and diffuse those traps one by one using some highly focused principles. Let's get to work.
Okay, picture this scenario. It's absolute chaos in the ER. A patient just arrived after escaping a raging building fire, literally jumped out of a third-floor window. They've got severe burns, and suddenly their hemoglobin absolutely plummets to 5. The examiner turns to you and asks, "What's causing this massive drop? Is it the burn?" Well, it's a classic misdirection.
And here's the answer, revealing our very first major cognitive trap. While severe burns do cause anemia eventually, that sudden, massive blood loss? Not from the burn at all. It's from the associated trauma, specifically a hidden hematoma. You see, a neglected femur fracture acts like this massive internal reservoir, hiding up to 2 to 3 liters of blood. This perfectly illustrates why your strict admission protocols mandate skull, spine, and long bone x-rays for any burn patient with a trauma history. Literally, if you miss the fracture, you lose the patient. So, our rapid-fire agenda for today. We're hitting triage and fluid resuscitation, pediatric pitfalls, special burns, Jackson's model, surgical rules, and finally, dressings and infection control.
All right, Section 1. Let's dive into triage and fluid resuscitation traps.
You probably know the Parkland formula dictates giving 50% of your calculated fluids in the first 8 hours, right? And the remaining 50% over the next 16. But here is the massive board trap. That 8-hour clock, it doesn't start when they roll through your ER doors. It starts at the exact time of the injury. So if a patient arrives 2 hours late and, say, already got a liter of fluid at an outside clinic, you absolutely must subtract that liter and push the rest of the first half over the remaining 6 hours.
And while we're on the topic of fluids, there's a strict rule for colloids. Never, and I mean never, use albumin or colloids in the first 72 hours. Why? Well, a severe burn causes a massive systemic capillary leak. Giving early colloids is basically like blowing air into a torn balloon. The proteins just leak right out into the surrounding tissue, they pull more water with them, and they make the edema so much worse. Just stick to crystalloids like lactated ringers.
Moving right along to Section 2, pediatric burn exam pitfalls. In an infant, the head is a massive 18% of their total body surface area, and each lower limb is 14%. You literally cannot use the adult rule of 9s here. If you just instinctively apply adult rules to a burned infant, your fluid calculations are going to be completely wrong from the very first second.
And because of that, there's a critical difference in your fluid targets. For a standard adult thermal burn, you're targeting 0.5 milliliters per kilo per hour of urine output. But for a pediatric patient, or actually any patient with deep electrical burns, you've got to aggressively push fluids to hit 1.5 to 2.0. You have to literally power wash those kidneys to flush out toxic muscle proteins, which we'll talk about in just a minute, and prevent acute cortical necrosis.
Pediatric patients also hide another deadly secret, and that's dilutional hyponatremia. The cognitive trap here is reaching for standard dextrose water out of habit. Don't do it. If you do, you're just drowning the child in more free water and making the dilution worse. You must actively correct that critical sodium deficit using 3% hypertonic saline.
Okay, Section 3. Let's look at high-yield special burns.
If you clinically prove an inhalation injury, we're talking singed nasal hairs or soot in the sputum, you have to immediately bump your calculated fluid resuscitation by 25%. Now contrast that with carbon monoxide poisoning, which notoriously hides behind cherry red skin. The massive board trap here is trusting your equipment. A standard pulse oximeter is entirely useless for this. It actually reads carboxyhemoglobin as normal oxygen. Crazy, right? You must treat immediately with 100% oxygen or hyperbaric oxygen, just to cut the half-life of that carbon monoxide. Now let's think about chemical burns. Acid burns cause immediate, searing pain, but alkali burns, like caustic soda, they have a delayed onset of pain. And this sets up a terrifying pediatric scenario. A child might drink liquid caustic soda thinking it's milk, and because there's no immediate pain to make them stop, they just keep swallowing. It causes this silent, deep corroding tissue destruction that eventually just perforates the esophagus.
Electrical burns have their own strict rules. Even a tiny domestic shock, like a toddler touching a wall socket, mandates 24-hour cardiac monitoring for silent myocardial injury. Plus, high voltage causes massive deep muscle damage. That dumps myoglobin into the blood, leading to red urine.
And remember when we just talked about targeting 1.5 to 2.0 for fluids? This is exactly why we power wash the kidneys. It even demands IV mannitol to help flush them out. Oh, and keep in mind, late developing cataracts are a classic, highly tested complication of electrical burns.
Section 4, Burn Assessment and Jackson's Model.
Imagine a glowing bullseye of tissue damage. Right in the center, you have the zone of necrosis, that's dead tissue. Surrounding that is the zone of stasis, which is ischemic, but it's salvageable. Then the outermost ring is the zone of hyperemia. The classic exam mechanism for this? Surprisingly, it's not a direct flame. It's actually a scald burn. Picture a patient fainting in a steaming hot shower. The exact spot the running water hits is your central necrotic zone, and as that water flows outward and cools, it perfectly creates those shallower peripheral zones.
Moving into the OR for Section 5, Surgical Rules and Skin Grafting.
The physiology of how a graft survives is fascinating, and examiners test it constantly. For the first 48 hours, a skin graft survives strictly by drinking up surrounding fluids, a process called plasmatic imbibition. It's only after that 48-hour mark that anosculation begins, which is when the actual blood vessels join up. So the absolute worst clinical error you can make is letting a graft dry out on the operating table before you apply it, because it completely destroys this delicate drinking phase. Examiners also absolutely love the surgical distinction, escharotomy versus fasciotomy. If a circumferential burn acts like a tight tourniquet around a limb or stops the chest from expanding, you do an escharotomy. You're just slicing through the tight, dead armor, the eschar, until the wound gaps open. Because the tissue is already dead, you don't even need anesthesia, and you definitely do not cut the deep fascia. A fasciotomy, on the other hand, is a much deeper cut reserved specifically for true muscular compartment syndrome.
And timing in the OR is everything. The countdown clock for deep dermal burns gives you a golden window of just 3 to 5 days for surgical excision. If you delay beyond this, the necrotic tissue just becomes a breeding ground for sepsis, pretty much guaranteeing your graft will fail. On the flip side, if you're observing a burn and it hasn't healed by 3 weeks, excision becomes mandatory to prevent severe hypertrophic scarring.
Finally, Section 6, Dressings and Infection Control.
Facial burns are left completely exposed. But the trap here is the topical agent you use. You absolutely must use a fat-based ointment, not a water-based cream. Creams dry out in like 30 minutes, whereas ointments actually keep the wound moist. Hands, however, are the exact opposite. They have to be strictly wrapped in closed, thick dressings. Because if you use a thin dressing on a hand or body burn and the wound fluid oozes completely through to the surface, you've just created a direct, wet highway for bacteria to travel from the atmosphere right into the wound.
Which brings us to the ultimate infection trap. Do not give systemic prophylactic antibiotics upon admission for standard thermal or electrical burns. Seriously, it's considered antibiotic abuse. It destroys the patient's normal flora and breeds highly resistant superbugs exactly when the patient will be entering that 3 to 5 day golden window for surgery we just talked about. The strict rule? Wait 72 hours, take a wound culture, and target your antibiotics based on those specific results.
Wow, we've covered a massive amount of ground today. So I want to leave you with a final multi-layered boss scenario that really connects all these rapid-fire rules. A 2-year-old child presents with a 20% TBSA deep electrical burn, red urine, and dilutional hyponatremia. What is your exact fluid and electrolyte strategy? Think about it. You have conflicting metabolic traps, differing kidney target rules, and strict timelines all colliding at once. How do you balance the ringers, the mannitol, and the hypertonic saline without drowning the child or destroying their kidneys? Master how these interconnected rules play off one another, and you won't just pass your boards, you'll genuinely save lives. Keep studying, and I'll see you in the next one.